Hello and welcome to Thoughts on Therapy. I'm Bryan Stevens, a licensed professional counselor with a practice in Marietta, Georgia, and the founder of TalkForward, who is bringing us this podcast today. I've been active in behavioral health for over 25 years, and in that time, I've met all sorts of knowledgeable people. Thoughts on Therapy is the show to bring their knowledge to the general public. Today, we're talking with Dr. Foluso, who is a licensed psychologist. She has a PhD in clinical psychology and has been practicing psychology for over a decade. She's the owner of Skill Set Counseling. She's licensed in both Georgia and Michigan and is part of the SIPAC certification program, meaning that she can see clients via telehealth in several states, all of which are within that SIPAC jurisdiction. And today we're talking with Dr. Foluso about obsessive compulsive disorder, which I think is a big topic. So talk to me. I think we'll just kind of open a little bit and tell me a little bit about yourself and your areas of specialty.
Okay. Well, first of all, thank you for having me on today, Bryan. I really appreciate it. Like Bryan said, my name is Dr. Foluso. I'm a licensed psychologist. My doctorate is in clinical psychology, and in my private practice skill set counseling, I see several types of, I'm open to seeing several types of clients. The areas of specialty for me are OCD, spiritual abuse, and cultural abuse or trauma related to those areas. And so that's where, I would say my areas of clinical focus are, although I do see other, other types of concerns. And then also with OCD, the type of treatment that I do for that is exposure response prevention, or ERP. Okay. And so I love the type of work it's really neat to be able to see lives change through therapy. So
yeah, I agree. That's I find it's very enriching work.
Yes.
To help clients do all the work they need to do to get better. Yes. I say to my clients, therapy is not something I do to you. Therapy is something that we're doing together. So
yes.
Well, let's talk. I'd like to maybe start with defining obsessive compulsive disorder, OCD, because that's one of those terms I think people throw around a lot. They'll say, "Oh, that's my OCD kicking in," or a variety of things, and I think maybe it gets misapplied. So I'd love to be able to talk to our viewers just a little bit about what exactly is obsessive compulsive disorder.
Okay, sure. Well, yeah, OCD, what I definitely resonate with what you said. OCD can be thrown around, and sometimes there's the colloquial or cultural understanding of OCD, of it being, maybe like a quirky or personality trait, but OCD is actually a debilitating disease, and it consists of two components. There are the obsessions, which are not only thoughts, they can be thoughts, but they can also be, they're recurrent and they're intrusive urges, thoughts, and images.
Right.
One or more of those. And if they cause anxiety for a lot of people, but they can also cause different sorts of reactions, such as shame and disgust. And so that is part of the obsession part. In order to neutralize those recurrent and intrusive urges, thoughts, or images, people engage in what are known as compulsions. And so this could be behavioral compulsions. What we tend to be most familiar with are behaviors like hand washing, for instance, or counting. But for many other people, they can be mental compulsions as well. So ways to reassure themselves or relieve that sort of anxiety that comes up. And so it can be, a silent disorder where people don't even realize the person next to them is going through that. And they're time consuming. They take about, at least the DSM-5 criteria says they have to take up at least an hour per day. But for people who have OCD, in my experience, it's much more than an hour per day.
Right. That actually makes a lot of sense. And I think in my experience with clients, the emphasis has always been on just how distressing, and I love the word intrusive.
Yes.
It's like, I don't want these thoughts, or I don't want these feelings, and it's like, where's that coming from? Almost like it's being poked into me. And then I engage in some sort of ritual or some sort of behavior or activity that kind of keeps the demons at bay.
Yeah.
Yeah, and it's very, of course, counting is common. What a lot of people don't, I think, realize is, of course, counting is you can count, and that will generally calm you down. It naturally decreases anxiety, which is why they, the old saw about going to sleep, counting sheep.
Yeah.
If I'm fully focused on counting sheep, I can't be thinking about all those things that are keeping me up at night. So,
Yeah.
well, what would you say then? So, I think a lot of people have thought of, oh, I'm hand washing, or I can't remember whether or not I locked the door is OCD. So, you're really talking about kind of a broader range of that. So what maybe are some kind of different types or subtypes if we're kind of digging into OCD that you see?
Sure. So, yeah, there are several. I mean, if you go do a Google search, you'll see several types. But if there's one instrument that we use in part of a diagnostic assessment of OCD called the DOCS, the Dimensional Obsessive Compulsive Scale, and according to that one, the 4 subtypes are contamination, and then the second one is like responsibility for harm, and then the third one is taboo thoughts, or taboo thoughts, basically.
Okay.
Unacceptable / taboo thoughts. And then the fourth one is symmetry. And so the different, that's one way of looking, but there's several other types that we see in the literature as well. People have anxiety and concerns about their sexual orientation. That could be one. Some about religious types, religious sorts of intrusive thoughts. That's where, my work with religious abuse comes in, or spiritual abuse, because sometimes when people have undergone really challenging spiritual situations, to cope with that anxiety and trauma, sometimes these related OCD symptoms can come up. So that's known as religious scrupulosity subtype, but there's several types of subtypes. And the important thing is that the treatment ERP for it tends to be, they'll change the types of maybe the types of exercises based on the subtypes, but as clinicians, we don't get way too caught up with the subtypes like sometimes clients can, because the underlying dimensions of the treatment are the same, and so with contamination, the one that I talked about before, that's one of the classical ones that you might see, perhaps in media, washing hands, things like that. Symmetry has to do with counting, or just having a feeling that something's just not right. Like, oh, I didn't complete that the right way. I didn't say that the right way. And then with the unacceptable taboo thoughts, the religious category sometimes can go in there with thinking thoughts that are taboo, or having urges that are taboo, but they don't originate from the person. And then, so I think, and so that would be, and then responsibility for harm is a big one. So with that, you'll see people who are concerned maybe about intrusive thoughts about harming one another, harming someone else. So they might feel they will not have knives or scissors in there anywhere close to them, because they're afraid they might act on an intrusive thought about hurting somebody. Having intrusive thoughts about, perhaps pushing someone down the stairs, or hurting them in their sleep, things like that. And again, these are intrusive thoughts. So these thoughts are, like you said, Bryan, distressing. It's like keeping these demons at bay, like you talk about.
Right. I think I had a professor once kind of said, trying to help people understand OCD that don't have it. I know a lot of people have experienced, maybe with heights, when you're looking down from a height, there's some sort of weird intrusive urge. People be like, basically, what would it be like to jump?
Yes.
That urge to jump. And so I've tried to use that with family members, is to say, now imagine, a lot of people say, I've had that. Now imagine you have that for 3 hours a day. About like stabbing somebody, or my hands aren't clean, or is the house going to blow up because I didn't check all of the lights, or that sort of distress is kind of the idea. I think we all have some intrusive thoughts at times, right? OCD is when it becomes this very distressing, ongoing, my normal things to control my thoughts don't work.
Right. And if you think about one analogy that I found very helpful is that, we, like you said, intrusive thoughts are not specific only to OCD, right? They did a study, they found that I think 97% of the population has all sorts of intrusive thoughts. But when you don't have OCD, your mind is working sort of, your mind knows that those intrusive thoughts can go straight to the spam box, right?
Right. Oh, I like that analogy. Yeah.
Yeah, that's one thing I learned, through my training is that, your mind will filter, okay, that's spam, whatever, it's an intrusive thought, that's it. Somebody with OCD, they're going to look at those intrusive thoughts the same way that they would, that their mind will treat it like it goes in the inbox into the same importance or even more importance because they're so distressing. And so a common belief with people who have OCD is that because I have this thought, then it must be reflective of my true nature, and then I'm going to act on this thought. That's something called thought action fusion. So believing that these thoughts are really important and it means I'm going to act on them, or it says something about me. So, not being able to separate the thought and the action is very difficult for people with OCD.
Right. Yeah, I think a kind of a classic one. And I've had this with kind of pattern with male clients, basically I noticed a pretty woman. And it's like, well, and that says something very bad about me because I noticed I'm married and I shouldn't be looking at other women. It's like, okay, well, you're kind of biologically built to notice her. You're not doing anything other than maybe, well, oh, there's a woman in a bikini that went walking by on the beach. But the guilt and the energy and the time that they spend after the fact just kind of way out of proportion. Because of the emotional import that they're attaching to it.
Yes. Or even if someone notices, with some of the subtypes related to sexuality, attraction doesn't mean that I'm attracted, right? So another man who identifies perhaps as heterosexual may see another man and notice, oh, he's handsome or he's muscular or well-built. But with somebody who has OCD, then they start to question their sexuality. Well, am I gay now, or what is my sexuality, right? And not being able to separate noticing that someone is attractive versus saying, okay, I'm attracted to them, and so that can happen also with people who identify as gay, and they might see someone of the opposite gender and notice that they're attractive. So it really doesn't have anything to do with the orientation per se, but the meaning or the label that they are attaching to what they deem as attractive.
Yeah. Makes sense. Well, so I think we're kind of have been touching on a little bit, but I'd like to maybe pick your brain on what maybe you see as some common kind of misconceptions about OCD. I mean, we talked about movie, right? The guy can't, what was that movie? As Good as It Gets, right? With Jack Nicholson's character, which I didn't think was actually that bad a presentation of somebody struggling with OCD, but that to me, that's kind of the classic presentation of I'm worried about getting sick. And I think he did counting, he did some of the counting his steps as well. But what are you see are some misconceptions that are kind of out there in the culture?
Well, media, like you mentioned, with the Jack Nicholson character, also Monk is another one too, that TV show. And so looking, people sometimes misconceive it as just like a quirk or a personality trait, or it's just, something that is really not as serious or as intrusive as the symptoms can be. And people, we all go through times where maybe we don't remember if we turned off, the gas or turned off a light or completed a particular task. Being particular about something or having strong preferences to do something a certain way is not OCD. That's just what maybe you like or you prefer. OCD is it's debilitating. It takes up a lot of time for people, just in terms of the amounts of the time they're spending with the rituals and the obsessing. And so it's really, and then also too, sometimes people just want to tell people who have this, well, just stop doing whatever it is you're
Right.
doing. And so they look at it almost as a quirk or a behavior that, or a personality trait that can just be sort of turned off and turned on. And this is there are neurobiological aspects of this disease. And so that's why it's not just a personality issue or a quirk or something
Right.
someone can stop doing. There was this skit a long time ago on Saturday Night Live when someone was seeing a therapist, and the therapist would tell the woman, well, just stop it. I don't know if you're familiar with that.
What made it funny, it was just Bob Newhart, who played a psychologist on the Newhart show back in the 70s.
Oh, I didn't know that. That's
Yeah.
interesting.
So yeah, which made it a little extra funny, I think. Yeah. He just stop it. Yeah.
Yeah.
Yeah. I've had that same commentary with depression. It's like, well, why can't you just pull yourself up by your bootstraps? And trying to explain to family members, yeah, that doesn't work. All the things that you do to make yourself feel better when you've had a bad day, they've tried and didn't work.
Yeah. Very
and
true.
Now they're depressed. They can't just stop it. There's some things we can do to help them think better. Medication can be helpful with depression. So let's try some different things, but just making it a character deficit.
Yeah.
Yeah. And I agree with you. I've seen that with OCD. It's like, this person would not spend an hour to leave their home if they had a choice. Nobody's choosing it takes me an hour to get out of my house.
Yeah, exactly. Yeah, that's that. And we need more of that compassion and that understanding, from the community at large, because there are people who have OCD. I mean, it can be very shameful for them. There are lots of, there's shame, there's secrecy, there's guilt because of just how consuming this disease is, and also how it can be misunderstood. Sometimes what people prescribe, they may be well-meaning in their intentions, but it can actually make symptoms worse, and people may struggle even more as a result of that to want to come forward and get help.
Right. Absolutely. So that's a good segue. Let's talk a little bit about treating OCD. And so if I've come to you as a client, what's your approach to treating OCD?
Well, I treat OCD using exposure response prevention therapy, ERP, or in some, so ERP is generally what it goes by. In some circles, it goes by EXRP, but same thing. And so with when in ERP, what we are, clients on a cognitive level understand that these rituals and compulsions and obsessions are not, healthy. They probably understand it to some degree, but ERP shows you that even though you are experiencing anxiety and it's distressing, it's not harmful, it's not dangerous. When we physically feel in our bodies very anxious, it can be, we don't want that feeling. We do what we can to avoid it. And so ERP will expose you, that's the exposure part, to anxiety provoking situations, the things that trigger the obsessions, whether it triggers anxiety, shame, disgust, a feeling of something's not right. That is what the exposure piece is, right? And so for somebody perhaps who has, we'll just go with a classic example of contamination perhaps, and they don't want to touch a doorknob, what we're going to do is create a hierarchy. And so at the bottom of the hierarchy, we're going to work our way up. We're going to see, okay, what causes you the triggers that will cause the least distress to the most distress. And we're going to work our way up that hierarchy. So for someone, it might be, I want you to close your eyes and envision touching a doorknob without any sort of, any kind of protection or whatnot. That might be something on the bottom. And then something else may be, okay, they touch it with one finger for 5 seconds, certain things like, so those are the hierarchy is key to ERP because it's a treatment plan. So we have that, we have the exposure part, but the response prevention is very important because that deals with the compulsions.
Right.
So when people are doing, when they're doing their obsessions and compulsions, it doesn't allow for enough time for the anxiety to go away on its own. So you know this as a practitioner, difficult emotions, as difficult as they are, they will either subside, or they subside in intensity over time with all emotions. But when people are doing compulsions, they're interfering with that natural cycle of emotions going away on their own. It's kind of short-circuiting it. So instead of letting the anxiety die down and you realize, hey, I felt horrible, but I wasn't in danger. When you do compulsions, you don't allow for yourself to experience that. Sometimes the anxiety may not habituate or decrease. But what you do learn from that is that, hey, even though this was really tough, I made it, right? So I touched a dirty doorknob. It felt horrible. My anxiety was at a 10 the whole time, but guess what? I'm still here. I made it. So
right. I got the other side. Yeah.
Yes, exactly.
So it's interesting, you know, one of the things I like to talk about clients with is the whole fact that our brains are designed to detect threats and protect us from threats.
Yes.
And they're designed to give us false positives, because
Ooh, that's good. Yeah.
we're better off mistaking a stick for a snake
Mm-hmm.
and then discovering it's not a snake than we are mistaking a snake for a stick, because discovering it's not a stick could be fatal.
Yes.
And as you were talking about it, I was thinking about it in those terms, the compulsions. It's like with the compulsions, what happens is I obliterate the stick. I never find out it wasn't a snake.
Yeah.
So my life is I do this obsessive compulsive, and there's some evidence I've read somewhere, there may be some evidence that we've got these specific circuits in the brain that are getting activated. But it sounds like I'm running around with my snake detection gear going off all the time. The doorknob's a snake. The dishes are a snake. I never get to learn that the doorknob's just a doorknob, or well, I may have mutilated my metaphor there, but that seems to be, yeah.
Got it. Yeah, because when we do when we're engaging in that behavior, it prevents us from learning. You're right. And the more learning experiences we have under our belts through ERP, then we realize, okay, anxiety may feel horribly uncomfortable, but I'm not in danger, right? You know, I can think certain things and have them not be true. Because another issue with OCD, you know, and this goes back to like the sort of just stop it is thought suppression, right? And so if I told you, hey, I don't want you to think about pink elephants, think about anything else but pink elephants for the next 1 minute, what are you going to think about?
Not only do I think about pink elephants, I've got the song from Dumbo suddenly revving up in my head.
Yeah, you know, and the research shows that that's what happens. There's a rebound effect. It depletes our energy when we're told, don't think about this. And that goes, you know, so part of ERP, you know, some of the work we do is obviously behavior, but some of it is also thinking too, and allowing yourself to not have to accept let those intrusive thoughts float by and not say, I'm not going to think about it. I'm not going to think about it, you know, because you realize, okay, yeah, I thought this intrusive thought about harming someone, but I didn't end up harming them. You know, maybe I might harm them the next time. You know, the thing with ERP is that we teach people that our goal is not to go to achieve certainty. We want to go through life understanding that, yes, we want control, we want certainty, but we don't have to have it to have a functional and happy life, you know what I mean, and a functional, positive interactions with other people. And when there's that OCD threat there, people are wanting that control and wanting that certainty. But we do things all the time without a guarantee of certainty. And so it's, you know, you can get in your car and you're going to trust that it's going to get you from point A to point B, even though you're not 100% certain. And so it's, you know, through ERP, we are learning that we don't have to have that certainty to be able to function and to move on and to get on with our lives.
Yeah, as you're talking about it, I'm feeling a lot of kind of like resonance on folks with panic disorder and agoraphobia, with a similar sort of pattern of, I don't want to be anxious, except I'm not engaging in a ritual not to be anxious. I'm disengaging.
Yeah.
I had a panic attack when I got in an elevator, therefore I'll never get in an elevator again. I'm not really afraid of elevators. I'm afraid of panic attacks.
Yep. Yeah.
And
That
so,
is.
but I never get to learn that elevators are okay.
Mhm.
And so, yeah, it's an interesting kind of a learning thing.
Mhm.
If I avoid my phobia, I never find out that it's actually, I'll be okay.
Exactly. Exactly.
So, well, tell me a little. I like this. I really like this approach, which I think is, back in the day when I was we talked about thought stopping techniques and all this other thing. So, what really kind of stands out as like unique and different in ERP?
Yeah, I think one thing that stands out to me is that we really, as clinicians, we have to stand back and not provide reassurance to our clients. And that's difficult for those of us in helping professions because we don't want to see our clients, we don't want to be the intentional cause of distress,
Right.
and when we're doing when we're doing ERP in session, I mean, ERP is very, it's hands-on, lots of work, lots of activities. And so when, I'm in a session with a client and we're doing ERP, it can be challenging for me to see a client, having a really difficult time getting through the exercise, even though it's something that they, we go at
Right.
a good pace and make sure that they, consent to it. But it's tough for me to see that. And it's also tough for them because I'm not going to tell them, oh, everything's going to be okay, you'll be just fine. They need to learn that, like you said, on their own, that, yeah, this is not a snake, or maybe it was a snake and I'm okay. So
Right.
that's one way in which this is a different type of therapy. And it's interesting because when I've seen people when I've worked with clients before who had OCD and maybe it wasn't detected, something that they've told me is that, from my other therapists, I would get a lot of reassurance. And while I felt temporarily better, it made me feel worse after, because they were getting a lot of reassurance about certain fears that they thought might or might not come true. So this is not a judgment on clinicians. I mean, we want to help people, but sometimes in our desire to help, we can interfere with the progress of treatment. And so clients, I think they understand that, look, we want to provide you with reassurance, but that is only going to contribute to your symptomatology. So we can validate them, and I think validation is great, helping them understand that their symptoms are experienced by other people, that what they're experiencing is real, valid, and terrifying at times, but that these exercises are going to help them. So that's one way ERP is
Right.
different. We really are trained, don't provide that reassurance. We can validate and we can encourage, but we don't want to feed into that cycle. So that's one way. And then another way is just it's very collaborative. And so I can understand the symptoms from a general perspective, but my client is going to be the one to tell me, hey, if I do this, this is going to raise my, it's called SUD, subjective units of distress. So we say on a scale of 1 to 10, how, distressed, anxious, disgusted are you feeling? And so when we're putting together the hierarchy, they're the ones that are going to help me lead that and say, okay, if I did this, or if I added this to the exercise, it would really raise my distress level. And so it's very collaborative in that way.
Right.
And
This is a
really relying on
9.5.
Yeah.
So I want to ask about the validation because I know in my own experience, just doing therapy, sometimes people, this is what I'm afraid of.
Yeah.
And, I've gotten a lot of mileage just saying, yeah, I get it. Yeah, I see why you're afraid of that. I understand. And validating their fears. Do you find that there's I said we're not trying to give them relief, but it sounds like your approach is helping them be seen. I guess you're have an approach that's giving witness to the thoughts,
Yeah.
and their power in a safe environment.
Yeah, you got that perfectly. Yeah, this is par for the course. This is normal for OCD. There's a lot of shame for clients when they discuss the type of intrusive thoughts they have, because they do cause shame, disgust, anxiety. So just even to be in the presence of someone that doesn't have like a horrified reaction or a judgmental reaction, is validation in and of itself, letting them know, yes, you know what, I've heard them all, you know, or I've heard one similar to this. This is par for the course for OCD. And so even just being in that environment where they know they're not going to be judged or, you know, just thought that well, wow, that's weird. You know, what's wrong with you? And therapists can do that, not just from what they say, but from body language too. So just being in that environment where it's calm, you know, this is par for the course, where, you know, we'll get through this.
Yeah.
Really helps.
Yeah, we'll get through this. That kind of makes me think the relief, or the validation I'm going to give you, I'm going to validate your experience. I'm not going to take away your suffering.
Yeah.
Right. Because you got to have your suffering. What I will say is, on the other side of this suffering,
yeah,
you've got this.
Yeah.
Yeah. So now this is really, and this, I think this will kind of lead well into my next question, but this is really hitting my substance abuse experience. Where so much of it, especially people kind of in detox and early res, is, yeah, it really kind of hurts right now. It's bad right now.
Yeah.
Trust the process.
Yes.
Right.
Trust the process.
Trust the process. We're certainly not going to come take your pain away from you. That's what you've been doing.
Yeah.
With your drugs. That's what you've been doing with your compulsions.
Yeah.
And so what I'm going to do is take those, we're going to take those coping mechanisms away from you that you don't really like, because they take up 2 hours a day.
Yeah.
But now you have to sit with the anxiety. So that may be answering this question, but you know what, OCD is kind of notorious in the therapist community, is kind of notoriously hard to treat, right? So I don't know, I don't see people with OCD, I want to refer them to somebody like you. So when you know, you hear that in clinicians. So from your point of view, is it hard to treat, or can you understand why people say it's hard to treat if
yeah.
Yeah.
I can understand why. One major factor with that is that it can be difficult to diagnose, because we have the classical definitions of OCD that we, you know, are familiar with culture and clinical work, but because of the ways that OCD can manifest in different sorts of ways that we've talked about, it can be difficult, you know, by the time I think it takes up to 17 years for people to get the right type of treatment for OCD. So by that time, it's gotten worse. And so it's going to be more difficult to treat by the time they come to the clinician who can provide the right resources. That's one. And then there's also another reason why it has the reputation of being hard to treat, is because, you know, what you referred to back with the substance use and saying that, you know, we can't take away the suffering. People naturally want to step in when they see somebody with OCD to help. And so family members, people in that person's environment can unwittingly keep the cycle going because of the reassurance that they're providing and stepping in when they shouldn't be. So for instance, you know, okay, so-and-so is doing their rituals again. Let's make sure we have this area cleaned off, this area sectioned off. You know, people who need a lot of verbal reassurance, people in the environment will give it to them. And that's only perpetuating the course of the disease. So that is why, and that can prevent someone from getting treatment, because, well, I feel temporary relief now. You know, so that's part of it. And then also just that the fact that many subtypes of it can be misunderstood. So sometimes for the clinician, if they're not fully aware of the different manifestations of OCD, they may misdiagnose somebody, or just continue to provide reassurance without actually getting to the root of the issue.
Right.
And then sometimes the treatments, you know, aren't helpful. So, you know, as we know, the literature in the mental health field is changing. So they might tell someone, oh, we'll just relax it away. They want to relax away the symptoms, and that is only going to make things worse. So
yeah, well, the whole, and that's a lot like with PTSD, right? Oh, you have PTSD and you've got anxiety. let's do a simple relaxation exercise, and the person's anxiety skyrockets because
Yeah.
what we've done is, well, we've taken away the distractions they're using to combat their
Yeah. Yeah. I mean,
sense of safety. And
yeah.
now they're like, I'll never want to see you again because
Mhm.
you just skyrocketed things for me.
Yeah.
So yeah, some similar things.
Yeah, I mean, it's hard for it. One of the biggest challenges, especially for parents who have children with OCD or any type of anxiety disorder, is not providing that accommodation for them, because we kind of it's sort of a default sometimes that we might do that we might not be aware of, and so not providing those accommodations and helping them learn, child or adult, to manage these things can be really challenging.
Right.
So yeah.
Yeah. Well, let's talk a little bit. I'd love to talk a little bit about the ERP, kind of
Mhm,
some nuts and bolts.
mhm, mhm.
How, kind of how it works in treating OCD, and maybe even, if I was a client coming in, what what would an ERP session look like? Because it sure doesn't sound like it's going to sound like Bob Newhart in the 1970s. So
Yeah, it really depends on what the underlying issue is. So of course we have that treatment, we have the hierarchy that we work on. We want to really, with ERP, we want to get to the root of what they're avoiding. And with anxiety and avoidance go hand in hand, because when people are anxious, they're going to naturally avoid things that make that anxiety worse or trigger it. So part of ERP is really doing not only a thorough initial assessment, but also assessing throughout treatment what's working, what's not working, what's getting that anxiety high, and so we can really get to it. So sometimes, for people that have, different, depending on what the trigger is, the exercise will be different. So one way ERP can work really well is by doing the exercises in session with the client. It's much more powerful than just having them do it and then tell you what they did. If we can work together in session and I can see how they're reacting and what they're doing, that's really important. So if somebody has an issue with harm and they harm OCD, and perhaps they're not keeping sharp utensils around, well, the first thing we might do is say, well, I want you to look at a pair of scissors. And telehealth makes this really interesting and good too, because we can look over, I can share my screen, we can look over different sorts of YouTube videos and ask, okay, what was your SUDS on a scale of 1 to 10 now?
right,
Oh, well, look at that picture of scissors. Oh, that was a 5 for me. Okay, well, we'll start here. If nothing was happening, let's figure out why nothing was happening. When with anxiety and avoidance, sometimes people can do these exercises but reassure themselves throughout, and that's not good. I want you to focus on that pair of scissors and think about how it could harm someone. I don't want you to think about blue clouds and the ocean and whatever to try and relax yourself. And so we really have to get to the internal process and make sure that they are
right,
following along. And when that's not happening, it's just unlearning behaviors. When you're feeling anxious, you don't want to lean into what's making you anxious. You want to fall back or dissociate and think about something pleasant. So, and when we're doing this in session, we're working on activities together. I want to see what they are feeling, what they're thinking, and then really engaging that response
right,
prevention piece. And then a big thing too is just congratulating them and having them get that validation, like, yes, you did it. Sometimes I'll say, okay, going back to the scissors, for instance. So I might have, I'll say, okay, well, here are a pair of scissors here, and look at me, and I'm pointing it into my hand right here. What is that level on a scale of 1 to 10 for you? And then now I want you, to do the same thing, or imagine, imagine what that would feel like, but we're working on things
right.
together in
Yeah,
session.
it's
And
a
it's
lot
very,
like systematic desensitization
mhm,
for a
yeah,
specific phobia, but it's very much like we're going to desensitize you to being overwhelmingly anxious. Yeah,
yes.
so you can
And then,
tolerate
yeah.
the anxiety.
Yeah, and not having that relaxation piece put in, because it's really important that you feel that you are not doing anything to take away from that anxiety. And then at the end, okay, someone might say, well, I thought holding scissors and putting them into my hand like this will give me, you know, something like a 10 on my scale, on a scale, SUDS 1 to 10, but then actually for them, it was an 8. And so sometimes, you know, clients will often find out that they overestimate the amount of anxiety they're going to
Right.
feel in a situation. And so I can tell you that all day, but when we're doing these exercises together, you learn that.
Okay. So boy, this really does sound a lot like treating panic disorder, because I'm
Yeah.
running away from the anxiety. And I think, kind of going back a little bit about what makes it hard to treat, I think for those therapists that tend to feel their clients' anxiety,
Mhm.
I can see that making them very uncomfortable.
Very, very much so. And that's part of what we have to do in our internal work as therapists, is understanding that, think about what's happening on the other side. And even sometimes being able to not personalize the maybe the difficult feelings that come from the client against you, like, why are you making me do this?
Right.
I don't think this is necessary, you know, and just being frustrated with you for not providing them that reassurance and talking them through that, you know, especially with panic, with ones that involve panic, because with ERP, sometimes people have obsessions and compulsions around bodily sensations.
Right.
And so when we'll do something known as an interoceptive exposure, in which they will do things such as, you know, it could be breathing through a straw, hyperventilating, jogging in place, spinning around in a chair, you know, just different things to make them feel physically uncomfortable. And while they're doing that in session, you know, my job is to sit back and let the process happen, not say, okay, you've got this, nothing bad's going to happen to you. So that's, you know, that's a part of the treatment as well. And it does overlap and target those panic symptoms as well.
Yeah. That sounds so. The other thing that kind of strikes me, having done a little bit of this when I hurt my back, kind of feels like physical therapy.
Yeah.
It's going to hurt.
Yeah.
It hurts. Keep doing it. Keep doing it.
Yeah. Yeah.
You know,
I've been through physical therapy too, and it is not fun.
It's like
when you're going through that. Yeah.
Except I'd leave having felt like I was run over by a truck. My back would work better.
Yeah.
You know, so I had this crazy notion that I was looking forward to go to physical therapy, even though it hurt and I came out of it worn out.
Yes.
But how
And
little
that,
improvement.
yeah. When you talked about looking forward to that, that is the sort of attitude that we want to foster with our clients. That yes, you know, anxiety is not fun to experience, but when you do these exercises, what is it like on the other side? Because, you know, part of what we do in ERP is we ask, how did you feel when you did this exercise, and what did you
Right.
learn? And so a lot of times learning that, well, this was very difficult, but I made it through, feeling a sense of empowerment. So that's really important. And then clients, as they progress through treatment, they're like, I want more of this, like bring it on sort of attitude, right? And that then they will, and this is just really rewarding to see, is that clients will start coming up with other sorts of ERP exercises on their own. Well, I did this, but I added this to it because I knew that I needed to have more anxiety so I could learn that I could cope with it. And so when you see them having that, yes, I want to go to physical therapy kind of attitude, but for ERP, that's really, it's just really rewarding to see, and rewarding for the client too, to experience.
Right. Well, it's like I went and did a day at the gym, and I come back and my muscles are shaky, but I feel good about what I did. It's like, yeah, I got through this, and I'm able to get to some. I should be kind of interesting to see research on. You get to the end of the kind of the ERP and session. Be interesting to see if there's a dopamine or serotonin rebound. Okay, you've been through, you're safe.
Yeah.
Now okay, well, that didn't feel great, but you know, some sense of satisfaction to it.
Mm-hmm.
It's just a snake.
Yeah.
Or it was a snake, but it's not venomous.
Yeah. That, you know, that sense of feeling competent, knowing that they can go through it and they can handle things. And with ERP, it's really a lot about skill building and not dependence on the therapist, because the themes of themes and subtypes of OCD will change over time. And so, sometimes someone might say, oh my goodness, this week I had this random obsession from like a different category of OCD, but because of what they've learned and what they've trained themselves to do, they can address it, because when we think about some of the older, psychoanalytic models well, I mean, not psychoanalysis is not necessarily old, but just some of the older applications of it, where there's this fostered sort of long-term dependence on the therapist.
Right.
ERP is different, and we are not just going to, throw you out in the water and let you figure it out yourself, but there is this idea of transference of skills that, look, I want you to learn to do this, and I want you to apply this in different situations, because thoughts might change. I can't guarantee you will never experience another obsessive thought or an urge to do a compulsion, but how are you handling it? How are you responding to these symptoms when they're coming up is very important. So like what you talked about with that feeling of satisfaction, at the end, that's what helps these clients, they keep going throughout therapy.
Okay. Well, so you touched on, like with the scissors, teletherapy, changing things a little bit. Because to me, this sounds like, boy, this is something I'm really doing in the office with somebody else, but you're doing teletherapy across the SciPact. So which sounds like a superhero organization in a Marvel movie to me. But so how does this work with teletherapy?
Yeah, so with teletherapy, it's amazing how this has opened up so many options. First of all, just in terms of access that clients can have to clinicians who practice ERP. So that's great in of itself, because of telehealth. If clients need to travel, as long as you're practicing, you can see them depending on where they are and what your legislation allows. So that's good because there's flexibility. And sometimes with clients, when we use telehealth, we can be very creative in how we implement these techniques. So before this, sometimes house visits, a practitioner would need to go to someone's home to see what they're doing and how their environment is set up. But with telehealth, we have technology that can do that. So we can be very creative in the types of exposure response prevention exercises that we do. It might be, okay, you're going to go in the car today, or you're going to go to this place today. I mean, obviously we have to keep like confidentiality in place, but we can get creative as to where they're doing the exposures, how they are implementing it because of technology. So it not only improves access, but it also improves our ability to be creative with different sorts of exercises.
Okay, that's awesome. Well, we are about running out of time. So I think what I'd like to do is with, if we had, let's say, a viewer who's got OCD right now, what would you want to say to that person?
Yeah, I wanted to say that, you're not alone. And please, get treatment, get ERP treatment as soon as possible, because the average, or, a number that's been put out there is about 17 years. It can take up to 17 years for people to get the right type of
scary.
So, yeah, it is. It's a misunderstood condition. So please get help today. There are practitioners such as myself who are trained in ERP. We will not judge you. We have heard all of it. So I understand there's a great deal of shame and secrecy and sometimes guilt around this, but we understand. We've heard different sorts of things, and we're not going to judge you or shame you. And so I think for a lot of, when I work with people, there's a sense of relief even after the first session. Like, I thought this was going to happen to me. I thought you were going to, call the cops on me because I had an intrusive thought about, pushing someone down the stairs. Or I think there's just a lot of scenarios that tend to be built up in one's mind who has OCD about what treatment is going to be like. And I encourage you that's when you see that a competent practitioner, that won't be the case. And sometimes it might take a little bit of work, but this is where the technology piece comes in. If you see someone and you don't feel like they're familiar with ERP or it's not a good fit, keep trying, keep going to the next person until you find a good fit. But we are out here, we
Absolutely.
understand OCD, and we are here to help, and we are invested in your progress.
Okay. Well, I will definitely put your contact information in the bottom, but how can people find you?
Yeah, so they can go to my website. My website is skillsetcounseling.com, and they can book a free 10-minute consultation with me. And I also have a YouTube channel too, which I post videos about OCD and some other topics related to mental health and spiritual abuse and cultural abuse, because religion and culture do play a factor. There are several other things that play, that factor into how OCD is manifested, but
Right.
I post videos on those. But yeah, the fastest way would just be to go straight to my website and click on the big orange button that says book a free 10-minute
Okay.
consultation. And we'll talk, and we'll figure out how we can get you some help in recovery.
That
So
would be awesome. Yeah, I'll definitely have links down below as we do this. Well, thank you so much. I have learned a lot about OCD. I don't have a lot of people coming into my practice identifying with OCD, but I have some takeaways. So this is like getting free CEUs for me as I do
Oh,
these.
great. Well, I'm glad I could help. And thank you for having me, Bryan. It's great when us, clinicians can talk and learn from one another. I also learn from you as well, too. So thank you for having me on today. I appreciate it.
Awesome. Thank you.
You're welcome.